Today's interview is with a subject matter expert of military medicine. He is formerly the Chief Medical Officer of the United States Navy. He was also the Chief of Medicine at Walter Reed. He now works as a CEO at a company called Transform Care, Inc. He once helped to diagnose a group of special operations soldiers with lead poisoning, some of whom had been mislabeled as malingerers. Thank you for joining us today, Dr. Kevin Dorrance. What does it mean to be diagnosed with a chronic multi-symptom illness?
Yeah, that's a great question. That is the designation that has been given to a variety or group of symptoms that are presented that don't have a known etiology. That's the term now used for Gulf War syndrome. It's really the absence of a diagnosis. When you describe symptoms as a diagnosis, that's not a true diagnosis from an etiology perspective.
Clinicians providing direct patient care are facing ever-constraining limitations on both time and resources. It seems fair to state that many feel it is not cost-effective to undertake a long and expensive workup for the somatic symptoms of a single patient, particularly when psychiatric causes might seem plausible. Would you be willing to comment on that diagnostic approach?
Sure. I think that, yes, the clinicians are, particularly primary physicians, care physicians, are faced with significant pressures, both time and productivity. And when you have complex syndromes and it's difficult to make an easy diagnosis, you end up with significant numbers of tests, and quite frankly, if a psychiatric diagnosis is plausible, that becomes often an easy route, if you will, particularly since there's tremendous overlap in terms of the syndromes that we're seeing.
Given the complexity and diversity of medical problems, it's not easy to ascribe causality to any particular case. So what can be done to look for patterns and criteria that should be targeted?
So particularly when you're looking at the cases that are designated or that are consistent with this multi-symptom illnesses, what really needs to be done is to do this, look at cases more in a population epidemiological basis. So you can look at large numbers of individuals that may have similarities in their presentations. They may have consistencies in the jobs and the work they performed. There may be other markers that can be discovered, whether they're biological, laboratory, or psychological. And that would help tremendously, is to look at this more at a population level than an individual level. I mean, what we discovered was clearly there's overlap between a lot of the toxic-related chemical exposures, other toxins, and psychiatric or cognitive symptoms that could look like PTSD or TBI.
When you say a lot of overlap, you mean through different types of exposure injuries or different substances?
No, meaning the syndromes, the way they present. So PTSD or TBI can have memory-related, cognitive decline, psychological changes, mood disorders, issues with rage or anger, and a lot of the chronic toxic exposure can cause cognitive decline, memory issues, and some of the same personality-related changes that are consistent and overlap between the two syndromes.
Do you feel that there is a sufficient coordinated effort to study these illnesses, be it government or civilian efforts?
Do I think that there's enough resources that are being expended? Yes. Do I think that they're being targeted or strategically used in a way that we can really get to the answers? No, I don't think so. I think that there's a lot of great work that's going on. There's a lot of great research. A lot of that research is very focused on one system. I haven't seen anything that's really been done that's comprehensive, that's trying to look for a source etiology for these syndromes that are clearly exist and have a mixture of different physical symptoms as well as findings that whether it's hypertension or other abnormalities in cognitive testing. So no, I think that there needs to be a much more focused effort, not just to evaluate people and put them on a registry, but actually to look at this at a much broader population, as I mentioned before.
What do you see happening with government funding for these programs right now, and maybe how could it be more effective than it is right now?
Yeah, that's a great question. The funds that are being expended, I mean, there are some targeted environmental and toxic exposure research that's ongoing. However, it's typically it's grants that are awarded to investigators that have projects that may have some relationship to the overall problem, but that don't look at this in a more holistic way. And I think that's the biggest problem. And when you look at historically, you understand that it's not as though we don't understand and know that their toxic exposures have occurred in these complex environments during a war and battle, and in nations that don't have the same resources. I mean, Afghanistan's a great example where we know that lead in the environment and lead being used still in fuel in vehicles and automobiles and gasoline, there's complex environmental issues that have to be understood and addressed in a much more forward-thinking way going forward. I mean, otherwise we're going to continue to repeat this cycle of people getting injured, misrepresentation of what those symptoms and illnesses are caused by. We need to accept that there is, the most likely reason for some of these complex syndromes is probably toxic exposures.
You're reminding me of a conversation I had with my wife a couple of years ago when I was trying to get more workup, and doctors just seemed like they were being very dismissive, and I almost felt like I was going crazy, and I asked her if that was her opinion, to which she responded, well, you've been overseas where they burned everything in sight, you've been in this sand that we know to be toxic, you've been blown up, which is a factor for lung injury. Why, if you have all these risk factors, would it be so hard to believe that someone could be having adverse health consequences because of that? But a lot of veterans are having these stories right now. What, from your perspective, both as a doctor but also having worked with a military population for all this time, do you think factors into that?
Well, it's interesting the way you presented your question, that am I going crazy, right? Is it me? And you have a unique perspective being in the medical field, but you also have a unique aspect to your personality in that you're persistent. And you can imagine that most patients, most people that are seeking answers, that receive an answer, accept that answer from the medical profession, and they're not persistent. So how many of those individuals are in the same exact category as you, but we're completely ignoring them or unrecognized, or don't recognize them because they don't have the same persistence? And that's exactly what I saw. There was a group that I cared for that were special forces, and they're a fairly unique personality type, and every one of them wanted to get back to duty. They wanted to get back to their job. That's not a typical patient that is malingering or that's fabricating their symptoms. Certainly, that same group also has a tremendous amount of risk for PTSD and other psychological and other injuries, TBI, and so they have a complex. They're in a complex warfighting environment, but they want to get back to their jobs, and they're much more persistent in terms of looking for an answer. I think that that's a critical aspect of it is, can you look at the individual, draw a timeline, look at their history, look at how their symptoms presented, and you have a much better understanding that this does not look like, somebody who has a pure psychological issue. And when you do the testing and when you ask for your, behavioral health, your psychiatrist and other colleagues to help you, you find that these are not, pure psychological. They may have some PTSD. They probably should have some PTSD, from my perspective. But they're not clean. It's not a clean, one-to-one, symptoms diagnosis. It's not that easy.
I'm going to extrapolate a little bit because I've never been a doctor. And to anyone who's listening that might think I'm trying to be a doctor, I don't want to. I can't be my own doctor. That's part of the problem that we veterans are having. It's my understanding that as you learn differential diagnoses and how to figure out what it is, what you think it is, and effectively treat it, I've heard several times this whole theory of Occam's razor, and you know where I'm going with this, that there's going to be one thing that's causing this kind of problem. However, many of these veterans are showing up with complex systems that involve multiple problems, multiple organ systems, and there can be more than one problem that they're having because of something. Like if they've got blown up, then it's reasonable that they have PTSD or should. But then they might also have other injuries. So what do you think about the whole diagnostic approach of saying, well, we need to find what the root cause of all this problem is, and how can we maybe broaden our net as we look at diagnosing these populations?
Yeah, no, and that's actually, you're spot on. I mean, that the likelihood, particularly in combat, and if any of the individuals that presented had any significant combat experience, it's not unlikely that they've had, or they may have had TBI. They may have PTSD. And so when you end up with TBI and PTSD, and you can to some degree relate those two and say that's a very common comorbidities, right? I mean that are related, that have occurred together. If you then immediately say, well, then I can explain everything else under that umbrella, you've completely misrepresented or potentially have missed other opportunities to look for other issues or causes of some of their symptoms. And if you can neatly fit everything under those umbrellas, well, then you can wash your hands and you're done with the case. You understand exactly what's going on and you move on. Unfortunately, again, you're talking about typically young individuals that are in complex environments and trying to fully understand where all of their symptoms might fit. It doesn't usually work that way. It's not that easy. You can try to force fit all of that underneath as TBI or PTSD or other psychological issues, but it's not always that easy. And when you end up with those cases where something just doesn't add up, why is there this uncontrolled hypertension? Why are these other abnormalities occurring? Why do you have these other symptoms? You have to be much more curious.
So you spoke about work that you've done with the Special Forces population, and you mentioned the term malingering. I mean, you're talking about people who frequently it takes years to build up a cohesive A-team, at least with Green Berets. Other teams, it takes a lot of time, a lot of training, a lot of money, and a lot of dedication. How many people, when you were seeing these types of cases, and other people have been involved in diagnosing them, were saying things like, well, we think it's malingering, and does that even make sense?
Right, no, and that was really what made me most interested and most concerned about what I was seeing, was that these are high-performing individuals, and if you're in the medical profession, you're a physician or some sort of healthcare provider, and all you're doing is looking at this from a medical perspective, you're doing the individual a disservice, because you need to match that up with their with their career. If their career has been consistently positive, if they've, and in the one case, 7 deployments, high performing, very, very intelligent individuals, how come all of a sudden now they're malingering? There's something, we're missing something. And particularly when they're looking for a way to get back to their job. The one individual that was a Navy SEAL, another individual was trying to get into the Delta Force. So those are not individuals where you're gonna stamp malingerer on their career progression. There's something happened that changed their ability to perform, that's affected them. And could it be PTSD? Of course. However, you need to look very carefully at those cases, particularly when they're trying to get back to their jobs.
Most research studies I've seen involving Iraq and Afghanistan appears to primarily focus on PTSD. I wasn't initially going to get into this a whole lot because this is another project I've got that's in the works, but I went to PubMed and just queried Iraq and veteran. As of yesterday, when you do that, there are 2,207 cases that come up of scholastic papers regarding treatment of these two population types. Of what I've searched through so far, which is about the first 200, I would say it's fair to say that somewhere between 60 and 85% of them focus on either substance abuse, opioid abuse, PTSD, or incarceration. I have been told from people who have fought this battle with the Vietnam era and Agent Orange that initially these symptoms were looked at as PTSD and other types of psychological or sociological problems. Do you think that there's a sufficient look at how we are studying this population of veterans post-combat?
No, I don't. As we talked about before, it's very easy to put everything underneath that umbrella of PTSD. And substance abuse, of course, is highly associated with PTSD. Self-treatment, and then the devastating effects of multiple polysubstance abuse. So when you look at it from what is the most common reason for a set of symptoms or a syndrome, it's very easy to sort of ignore other possibilities. And despite what we said before, despite the historical context where we know that toxins have been associated, going back, for decades, in these wartime environments, in these battlefield environments.
You have been looking at trying to coordinate efforts to develop a toxic exposure research facility or organization. Can you describe what that looks like a little bit better for us, what it is that you're hoping to do?
Yeah, absolutely. The goal is to be able to look at, both historically and current, how can we better establish protocols, better understand, first and foremost, are we seeing or can we define environmental and toxic exposures that are clearly, from a causality perspective, the reason for some of the syndromes, at least. It may not explain all of the symptoms, but if we can put together a better understanding of the population, the environmental exposures and or the toxic exposures, then we can start to establish preventive measures, and we can also start to look at patients that are currently suffering. So it's kind of a combination of epidemiologic, ongoing research, and then clinical research. And the idea would be that we would no longer be in the denial, in a position of immediate denial, which is where we're at, today. That we're now in a curiosity. Let's have some intellectual curiosity. Let's do the right research. Let's put some science around this. before we say, no, your symptoms are all related to, psychological.
So that's working day in and day out with physicians. I don't want to seem like I'm trying to paint them in a bad light. I respect the fact that, number one, if you're the one who's diagnosing, you're the one who's got your own license, and you have to do what you think is right. But obviously there's a certain difficulty with hearing the same things over and over again and knowing that a mistake is happening. But one of the things that I've really seen is there's this push, it looks like, to just memorize algorithms and treatment care plans, which definitely are wonderful for if you have a patient dealing with like an acute MI situation or sepsis, even COVID to a certain extent. But that it doesn't seem like we can use this for everyone, at least not until we have standardized patients. So how would you encourage other physicians and practitioners to think when coming across these issues?
Well, I mean, first you have to recognize or believe that not everything's going to fit inside the box that you were where you were trained, and if there's good science that shows that there are overlap in terms of symptoms related to PTSD or even the burn pit issue, right? So yeah, I can potentially give you a diagnosis and or treat you for a set of symptoms and make you feel better to some extent. But if I don't have the intellectual curiosity to say, well, could it be X, Y, or Z, then you're missing a significant amount of there's a significant amount of value, and I call it intellectual curiosity. I think that as physicians, our training is, if it doesn't fit or meet what I've been trained, what I've been taught, too often we simply deny that that other possibilities can exist. So I think that first of all, if we don't get it into mainstream medical education, if we don't have clearer understandings, then we're not going to be able to train the next generation of physicians to think differently. And I think that we are so super subspecialized today that it's very, and we have significant time constraints, that it's very difficult for physicians to accept anything that doesn't fit within their domain. And it's challenging, and I don't think that's going to change until we have the science. We have to definitively prove that what we're saying is right, is true. And that hasn't happened. I mean, that hasn't happened today. I mean, we do know, we know about a lot of environmental and a lot of toxic exposures that have that result in certain syndromes. We don't see them commonly, so they're not in our repertoire from a day-to-day basis to be able to think, okay, could this be lead? Could this be some other heavy metal? And then the testing is poorly understood. I mean, I learned through the lead cases very clearly that my knowledge of lead exposure and our ability to detect it and the natural history of what happens with lead in the body was inadequate. And the tests that we have are just we run heavy metal tests all the time, but little did I know that they were useless because of the temporal association with the toxin. And that's really, I think, where you end up where we struggle. So if temporally your toxin, whether it was burn pit, whether it was, inhaled toxins, or whether it was, ingested or even through the skin, at that time of that exposure and the time of the presentation, they're so far apart in many cases, unless you happen to find something acute, you're going to end up with potentially long-term exposures over time that have a cumulative effect, but you can't necessarily prove them at the time of presentation.
So I want to see if I can build on this a little bit more too. Having spent at least a little bit of time in ER, I can recognize that a lot of physicians will get a lot of patients coming through saying, hey, I just learned about this diagnosis on some source I consider to be reputable, like Jerry Springer, and I can understand where if you've seen 5 of those cases during a day, that it would be difficult to give credence to someone who says, I'm a veteran, I'm having trouble breathing, and I've heard of other veterans having this issue. At the same time, there also seems to be a lack of understanding. I don't know how many times I've heard from different physicians I've been to, why don't you just go to the VA? And they don't seem to understand that, first and foremost, I don't even have VA coverage right now,
Right.
but more importantly, so many other veterans don't have that coverage, which means that really we have to be able to come to our primary care physicians and physicians we have around us and get more of a look into what's going on. Is there anything that you would say about that?
Well, the problem that you have is causality, right? So how can anybody subscribe causality to your symptoms, right? So you presented with your pulmonary issues. A pulmonologist can easily say, well, it can be due to these 10 other things. So that causality is what we're looking for, right? And when you have a dispersed population, you can't look at them from through a population lens. So the individual provider is seeing the individual, and I know what I know what I see, I know what I treat. Your lung disease is your lung disease. I am not going to make the leap, that there was a causality from an exposure that happened, 3 or 4 years ago. It's impossible, and you're not going to be able to find clinicians that are going to make that leap. And because of that, and because you're one of one, you can't start to think, in a larger context. Well, if I took all of those one of ones, now do I have 10,000 individuals? Do I have truly what I can now look at that epidemiologically and statistically doesn't make sense? Why do these individuals that may have had various different deployments, but all had some consistency in terms of potential risk for exposure? Now you have something to start to look at. And that's what we're missing. That's what I think we've been missing for a long time.
Sorry, go ahead.
No, and I was going to say the lead example, I think, is such an easy example because we do have tests where I can test you when you enter the military, and I can test you periodically and understand what your cumulative lead exposure has been over time. And in those cases, we can go through temporally and look at your training and do the same thing. And it's not just lead levels. And so there are ways to start to think about these exposures and potential risks of those exposures. Is what are all the likely environmental and toxic exposures that you're going to face in your career, depending on what you do. I was a gas-driven electronics guy, right? So I was a fleet guy for 10 years, enlisted. I now know there are chemicals that I used every day, literally had my hands in,
Right.
that are now no longer available. You don't use them anymore, and we know that they're carcinogenic. They're highly toxic. Did we go back in time and study the populations that would have been, that would have been my exposures? Dry cleaning solvent and trichloroethane and a number of other synthetic lubricants and all kinds of other materials that we used on the ship. Has there been any thought in terms of looking at you as an individual? What is your career track? What should we be looking for? And looking at that longitudinally. And it's not happening today. There are some. I mean, think about a radiology technician or a radiologist, right? I mean, we do follow their exposure. Why would we not consider doing the same thing for an infantryman who's going to fire thousands of rounds in their career?
Well, and you are talking about the whole longitudinal tracking. It would seem from most of, at least what I've seen with these various organizations, that a good deal of these cases are going to be indolent presentations, so you wouldn't expect them to be, when they first get out, when it would make the most sense automatically.
Yeah, the majority of them, or many, I mean, it's going to be a spectrum, right, where there are potentially high-risk exposures that are going to have more immediate repercussions, whereas others may be, a long-term much more, like you said, much more indolent, and you may not see, the lymphoma or the leukemia or whatever, for decades or for many, many years.
But then, like you also say, it is part of a spectrum. One of the things I see with the average pulmonary doctor is they seem to think that, speaking to bronchiolitis obliterans, that it's this esoteric diagnosis that you're going to know it when you see it because the patient will be on death's doorstep. Yet most pulmonary doctors I've seen also agree that they're aware that veterans are starting to have problems with that issue. But at the same time, there's only been, at least as of last year, there's only been 2 veterans that actually needed lung transplants.
Mm-hmm.
So it seems like it's also been just a challenge to get people to recognize that, hey, you might think that they're going to be this kind of picture that you've never even seen, but then not realize that it could be sitting right in front of you and you just don't know it.
Right, and we haven't done the population-based work, right? We haven't
Right.
said, those 2 lung transplants probably, from a numbers perspective, are statistically consistent with the general population. So you really need to look at this. Like you said, the one-on-one issue is the problem.
Right.
If I don't consider, from a systems perspective, is it possible that environmental or other exposures are causing these symptoms or syndromes? Then we're never going to know. And I think that's where we have to say, what is the population? And the other problem is it's not one thing, right? I mean, you had the mustard gas issue in Iraq. You have the burn pit issue, but what else, right? I mean, we've been screaming about lead for a long time, and the data in the general population is very clear. Lead is not a good thing to be exposed to at any amount, and to say that there is an OSHA, it's okay to get X. Well, what's that based on?
Mm-hmm.
That science is pretty clear today that we know that there's no such thing as a safe amount of lead exposure.
Right.
So therefore, why are we not considering that in a military unique population that has a high risk of exposure, that also can extrapolate into the general population?
Okay, so that's something I wanted to talk a little bit about also. The look at the pulmonary issues, one of the concerns that we found is, or that the doctors researching this have found, is the nature of the sand out in the Middle East. It's very fine, it's jagged, it gets into your lungs, it's cytotoxic, or at least mildly. And it's been compared to the dust that the 911 responders, or excuse me, the 9/11 responders inhaled during 9/11 when the planes crashed.
Right.
So not only do you have the group of firefighters who've been exposed to this, but you also have all the general people who have been living out there. So it seems like there would be a good reason to want to learn more about any pathology, because you never know when you run into it, especially when you consider how many new technologies we use every day that have come often from things that we've learned in war.
Right. No, that's a great comparison, right? I mean, the population around the Twin Towers, around all of that exposure that they had, and the fact that you're having these clusters of cases that are not inconsistent with some of the things you're seeing in the military. I mean, those populations, understanding whether does it have anything to do with the dust, or is there something else in the environment? But until we take it more seriously in terms of understanding the science, we're never going to be able to to move to that next step, which is, okay, now how do we prevent this? And not just in the military, to your point, but from a national and exposure perspective. I mean, how about other firefighters? I mean, they're exposed to all kinds of things. So it'd be interesting to look at those populations a little more closely. And there may be studies. I'm less familiar with the pulmonary data,
Right.
And inhalation. I mean, my work was fairly exclusive to the lead issue.
What is your next goal for addressing this population?
Well, we've been pretty persistent in terms of trying to get congressional support to get somebody to recognize this. When I was on active duty, I worked to bring the services together in the VA, and there were some changes that were made that were significant. However, I don't think it's enough. I think if we know there's an issue, then we know that there's a population that's probably suffering. And that's where I think we need to continue to try to get support from Congress to work together, between our nonprofit organization and other nonprofit organizations, yours and the other veteran organizations that are out there. If we could work collaboratively, I think we'd have much greater success. Trauma, the trauma of war, combat injuries are so visible and so easy to see that it becomes an easy path to sort of forget. There's a lot of other injuries that we're not addressing, whether they're psychological or substance related. Those individuals deserve to be treated just as much, and their injuries may not be functionally, physically as devastating as one might be able to understand or believe, but they can be remarkably debilitating from a cognitive perspective, from a psychological perspective, and from a functional perspective. So I think we need to those less visible injuries need to be recognized and understood better.
Is there anything that the average person who's watching, who's not either congressional or part of a VSO, can do to support these efforts?
Well, certainly. I mean, support your organization, support other veteran service organizations. Contact their congressmen. I mean, there are a lot of other avenues to be able to either volunteer to provide help or provide some financial support, and very importantly, talk to their congressmen.
You mentioned earlier how sometimes or frequently veterans may not persist. We've been talking about a lot of the challenges that we have in our current climate and system, but it seems like there also needs to be a little focus on helping either enable or get other veterans to recognize that they need to follow through more with this, because it can't just be your efforts, it has to be my efforts too, and us meeting somewhere in the middle.
Right.
Is there any recommendations that you would make to them?
Yeah, absolutely. I think they should reach out to groups like yours, to reach out to other veteran service organizations. The one thing you mentioned, that a lot of these veterans don't have any benefits, so they're either left with whatever health care they may have if they're employed, or Medicaid, and it's difficult to be able to to make the leap between a psychological issue and something that may be completely unrelated to PTSD, and you're not going to get it through those avenues. Those paths aren't going to work. So we do need to, and one of the things that our nonprofit is doing is trying to put together a better way for outreach, an avenue to be able to become an advocate for that individual, and it's very complex, because you're going to have a lot of psychological issues, and it because of that, you have to be able to figure out how to to individualize each person's needs and address them. And I know a lot of veteran service organizations are out there, but I don't know if they're really looking how closely they're looking at some of these other issues, and I think that we just need to bring them to the forefront.
Is there anything further that you would want to add?
No, I want to thank you, and I would thank all the other organizations that you guys work with that that you're taking this up, because it's not, by no means is it. There's not a lot of people that are willing to take on these medical issues that are not mainstream, that are quite often you're treated as a quack if you're trying to bring some of these things up, and I think that that's probably that's generally what happens with with new science and new learning in a field that is fairly dogmatic in terms of its approach, and medicine has really, in many ways, gone in a direction when it comes to clinical practice to being fairly rigid and fairly dogmatic, and it's hard to break through. So I think persistence is really what's going to either lead us to getting the right answers, or at least to drive other scientific and research efforts to be able to get us the right answers.
There is this image that I sometimes have through some of the experiences I've had both with ER and other physicians, but almost of it like it feeling like I could walk into an ER or be wheeled in with a bag over my head, barely getting air, and it seems like as soon as someone finds out I'm a veteran, they're going to be more likely to give me 5 of Haldol and 2 of Ativan than to actually take the bag off of the head. It's interesting because my mom had recommended a book to me a while back about the assassination of James Garfield, and if you look at that, you can see the best medical minds that they had at the time that were doing things like poking holes in his wounds and saying that there was a satisfactory amount of pus in the wound to indicate good healing, because that's what they thought they were doing with the best at the time. But I appreciate that as you've been dealing with this, you've been able to help veterans like us that are dealing with this, and that you've been willing to listen to us when so many times other people haven't. So thank you for your efforts as well.
I appreciate that, yeah. No, that's a great example. And most young physicians, hopefully they make that mistake once of saying it is X, it can't be Y. I did that early in my career, and I learned that lesson, that we are not in a medicine is not a complete science. If it were, you wouldn't need physicians. You would be able to do this with technicians, and so we don't know enough. I mean, our knowledge is incomplete, and if we don't accept that, we're never going to have the right intellectual curiosity to be able to solve problems that we don't recognize as problems. So, no, thank you very much. Appreciate it.
Thank you for joining us, Dr. Kevin Dorrance.